It's bro.
Okay, sige. So, our topic for today is the posterior or the infratentorial level. So, more likely, this will be a very, not that hard topic for us because this was already discussed or a part of it was already discussed during your neuroanatomy, okay? So, we spent about 10 hours before. So, for now, we will tackle more on the clinical side of the posterior or the infratentorial level, okay? So the primary objective of this lecture is to, for example, a patient will go to you, came in due to a complaint. So I want you to immediately focus more likely your attention or your thinking that more likely this is a posterior fossa lesion, okay? So it would be different in neurology since you will do neurological examination and you will tend to correlate all those things, no? Unlike, for example, in other systems, so a patient will go to you, came in due to right lower quadrant pain. So more likely, what's your impression there? Right lower quadrant pain. Hello?
Appendicitis po.
Yeah, more likely, di ba? Appendicitis. But in the brain or in neurology, for example, the patient will go to you came in due to frontal headache. So you cannot actually tell if there is a lesion in the frontal lobe region, no? Unless you will do the neurological examination. So what I mean is, at the end of this lecture, you should be able to track or to think as quick as possible that more likely we are actually dealing a posterior fossa lesion, okay? So first of all, I would like to discuss the boundaries of the posterior fossa area, okay? So the anterior part or the front side of the cranial fossa or the infratentorial level is actually your clivus, okay, this one, no? The posterior part is your occipital lobe, and then the anterior part is of course your brain, no? The brain, the cerebral cortex, primarily the diencephalon, okay? And then the inferior part is your foramen magnum, okay? We are not telling to you the boundaries just for you to memorize, but it do have a clinical implications, okay? So we have actually a case before during our residency, a case of a 45-year-old female, no, came in due to slurring of speech. And on neurological examination, we only noted tongue deviation to the left, okay? So more likely, where will you localize your lesion? There is a tongue deviation. Is it, okay, where is your lesion there? Localize the lesion. Your? Midbrain, pons, medulla, or none of the above? Okay, so some answered medulla, okay? All of you kindly look your thumb. Okay, your thumb is as small as your brainstem. Okay, that is actually the size of your brainstem or even smaller, no? So can you imagine? It is very small and it is yet subdivided into three main areas, no? Your midbrain, the pons, and then the medulla. Okay, and then it is bombarded with several nerves or nuclei, okay, or different structures. It is so unlikely, no, that only the cranial nerve 12 is affected there, okay? So if you will review, no, so for example, this is your medullary area. Very important for you to note that the medullary area is divided into lateral, no, and the medial, no. In the medial portion, you can actually locate your cranial nerve number 12, the pyramids, no, the motor system, and we have here at the middle your medial limniscus. Okay? So medial limniscus is for pain and temperature, no, sensation. Of course, motor cortex, motor system here, the pyramids, and of course your cranial nerve number 12. Okay? So since the medulla is very small, okay, so more likely, if there is a lesion here in the hypoglossal nuclei, all of these structures nearby will also be damaged. Okay, do you get that? Hence, more likely, if you have a tongue deviation, more likely you'll also have numbness, okay, on the same side or on the contralateral side of the body, and more likely there might be a motor problem. Okay, do you get that? Okay, such that when I asked that the only neurologic problem is a tongue deviation to the left, no, more likely the lesion is not in the medulla. Okay, because if it is in the medulla, more likely that other structures will also be involved. Do you get that? Okay, hence there are other areas in the brain from the hypoglossal nuclei, okay, here, it will actually exit, right? Okay, then it will actually go here. It will actually go here in your clivus region, and then it will exit in the hypoglossal canal, okay? So no, during our training, no, that is actually a contest, no one got the correct answer. My answer then was the hypoglossal canal, okay? Because the hypoglossal canal, it is actually where the hypoglossal nerve will exit, no? And you can only locate there an isolated cranial nerve 12 palsy, okay? The patient actually suffered from a clival tumor, okay? So there is actually a tumor in the clivus compressing the hypoglossal nerve. Okay, do you get that? So what I mean is, if you are entertaining an isolated cranial nerve problem, do not focus your attention inside the brainstem, because more likely, because it is very small, there should be other manifestations that you will encounter. Okay, so of course we can encounter a clival tumor, no? The significance of this occipital region is when, for example, there is a bleeding here compressing the cerebellum, usually your neurosurgeon will actually do suboccipital craniectomy. Okay, so they will remove this one, okay, the occipital lobe, so that the cerebellum can actually breathe, no? And it is actually a life-saving procedure. Okay, of course, any lesion superiorly can actually compress, okay, the brainstem, causing damage of the different structures. Okay, it can actually cause coma, because remember that in the brainstem, we can actually locate your ARAS, no? The ascending reticular activating system. Its main function is, of course, for wakefulness and arousal. Okay, and then we have here inferiorly, when you have a tumor in the foramen magnum, usually the cranial nerve that will be affected is your, what do you think? What cranial nerve? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. What do you think? Okay, so the first that will get the correct answer will give a point. What do you think? What cranial nerve? Okay, Sander, Yanis, correct, no? The spinal accessory nerve, no? Because uh, remember that the spinal part of the cranial nerve number 12 will actually originated or start, it will start from the cranial nerve number, cervical 2 to 7. Remember, di ba? I will buy C2 at 7:11. Okay, so it will actually compress, no? The when there is a lesion in the foramen magnum, it will actually compress the cranial nerve number 12. Okay, so that is actually the significance. That's why we are lecturing or telling to you the boundaries of a certain area. Okay, not just for you to memorize, no? Okay, so for example, a patient will go to you. Okay, another. So at this junction, so since we are talking about the different foramina, this is actually must know, no, board exam questions, no. There are several foramina inside the brain where the different cranial nerves will actually exit, no. So for example here, your cribriform plate for your cranial nerve number 1, of course optic canal, cranial nerve number 2. We have here the superior orbital fissure. Okay, it is where cranial nerve number 3, 4, 6, and the ophthalmic branch of cranial nerve number 5 will exit. Okay, so just remember that cranial nerve that will enter the eye, okay, will actually pass through the superior orbital fissure. Okay, so the ophthalmic branch, cranial nerve number 3, 4, and 6, no? The foramen rotundum, maxillary branch, or the V2. So always remember the romax, rotundum, maxillary branch. Okay? Ovale, oval man. Okay? Mandibular branch of cranial nerve number 5. Okay? Foramen ovale. Internal acoustic meatus, facial nerve or cranial nerve number 7 and cranial nerve number 8. Jugular foramen, cranial nerve number 9, 10, and then 11. And of course, hypoglossal nerve, cranial nerve. Actually, your okay? So your cranial nerve will actually go here and then it will exit there. Okay, go into the tongue region. Okay, do you understand? Now, I have a patient complaining of diplopia, okay, or doubling of vision. On neurological examination, I noted that the right eye is frozen. Okay, so meaning it cannot move upward, downwards, lateral, and then medially. So the right eye is frozen. Okay, and then I also noted numbness on the right forehead region. Okay, numbness or sensory deficit in the right forehead region. Okay? So localize the lesion. Letter A, midbrain. Letter B, midala. Letter C, letter A, midbrain. Letter B, pons. Letter C, midala. Letter D, none of the above. Okay? So you should all answer. You should all answer. The first one that will get, get the correct answer will get a point. Okay? So letter A, midbrain. Letter B, midala. Letter C, letter A, midbrain. Letter B, pons. Letter C, midala. Letter D, none of the above. Okay. So remember, we have the cranial nerve number 3, 4, 6. And then cranial nerve number, what cranial nerve innervate the forehead, the sensory part? The cranial nerve number 5, 1. Okay? So no one got the correct answer actually. Okay, why? Because, so remember this is your midbrain, pons, and then medulla. Okay? So always remember the rule of 2, 2, 4, 4. Okay? So cranial nerve number 1 and 2, supratentorially located. Cranial nerve number 3 and 4, located here. 5, 6, and then 7, located here. And 8, and then 9, 10, 11, and then 12. They are located here. So we have a lesion in cranial nerve number 3, 4, right? We have also a lesion in cranial nerve number 6 because the eyeball cannot move, no? So all of the different muscles are affected. We have also a lesion in cranial nerve number 5, okay? So meaning, we have a lesion in the midbrain and then in the pons, okay? However, as I have said, if you have those lesions, more likely, no, the patient is already comatose because the aras is located also in that region, okay? So more likely, the lesion is outside the midbrain or the brainstem. The lesion is actually here in the superior orbital fissure, which you can locate your cranial nerve number 3, 4, 6, and the ophthalmic branch of cranial nerve number 5. Okay? Do you get that? Okay, so if you have those different symptoms without any other or without any other manifestations pertaining to the structure inside the midbrain, more likely the lesion is actually outside the brainstem. Okay? Do you get that? So for example, I have a patient complaining of hearing loss on the right. And on neurological examination, I also noted peripheral facial nerve palsy on the right. No other deficit noted. Okay, so more likely, your lesion is here in the internal acoustic meatus, where the cranial nerve number 7 and cranial nerve number 8 will meet. Okay, do you get that? Yes or no? Okay, so I hope it's clear. So now, how will you know that there is a posterior fossa lesion? Okay, so definitely you should able to answer the 4 neurologic questions. No? So again, what are these? So number 1, is there a neurologic problem? Where is the lesion? What is the nature of the lesion? What can we do to that lesion? Okay, so I know you all know this. Okay, now, let me deviate first. Let us discuss first where is the lesion. Okay, meaning the neuroanatomy side. Okay, so where is the lesion? So always remember that when we say where is the lesion, we should do levelization, levelize, lateralize, and then localize the problem. Okay? So again, how will you do that? Of course, by doing your neurological examination, doing the cranial nerve examination, doing the cerebellar signs, okay, doing the motor testing, sensory testing, etc., etc. Okay? So again, so if this is the cerebrum, okay, we have here the first part of the brainstem is your pons, followed by your medulla, followed by the midbrain. Okay, right?
Wrong.
Okay, and then wrong. Okay, so this is your midbrain, the pons, and then medulla. And then of course, here is your fourth ventricle and then the cerebellum. Okay, so always remember the dural reflection that delineates the two, your, what do you call this structure again? Your tentorium cerebelli, okay? So, superiorly, supratentorial area, and then inferiorly, infratentorial area, okay? That is how you will levelize. So, if you have, for example, a cranial nerve deficit in your patient, more likely, you should be able to levelize that in the infratentorial area, okay? How about lateralization? As a rule again, no? So all lesions that are located infratentorially should be contralaterally or ipsilateral to the lesion. Ipsilateral or contralateral? Ipsilateral to the lesion. Okay, so always remember that same side, no? When we are talking about the cranial nerves, okay, so when we are talking about the cranial nerves, it should be ipsilateral, okay, because they will not actually decussate, no? They will exit, okay, as is. There are no decussations, no? Unlike, for example, the motor part, no, or the pyramidal tract, it will actually decussate in the medullary pyramids. That's why a supratentorial lesion will always manifest as a contralaterally to the lesion. Okay? Do you get that? Now, how about localization? So always remember In order for you to localize the lesion, you should be able to locate the different cranial nerves that are located there, okay? By the way, how many cranial nerves do we have? How many new cranial nerves do we have? Okay, so kindly key in your answers. All of you should answer. So letter A, 12, letter B, 13, letter C, 14, letter D, 15. Letter A, 12, letter B, 13, letter C, 14, letter D, 15. Okay, most of you answered B, no? And C. How many cranial nerves do we have? Okay, so earlier, actually, some of you and some of my previous students asked me, Doctor, there is a journal or a paper saying that there are other cranial nerves. We have other cranial nerves other than the cranial nerve number 12, okay? So this was actually lifted in Facebook, no? So as we, okay, so always remember the rule of 2244, okay? So always remember the different functions, okay, of the different cranial nerves. So as you can see here, they actually added two more, no? The terminal nerve and the intermediary nerve, okay? Now, strictly speaking, when we say cranial nerve, the definition of cranial nerve is nerves that will exit the brain independently, okay? Okay, however, unfortunately, cranial nerve number 13 and cranial nerve number 14 are still under investigation or under still study, no? They are still studying it, okay? Some say that the terminal zone or the zero zone or the zero nerve, okay, is actually a branch of the olfactory nerve, no? Okay, that's why as of now, terminal nerve or the zero nerve is not yet included as a cranial nerve. Okay, so probably in the future, no? Who knows? Intermediary nerve is actually a branch or ramification of your cranial nerve number 5 or cranial nerve number 7. Okay, so it is not yet proven that these nerves are actually independent nerves, no? Probably among animals, no, they are saying that among animals, they are actually independent, okay? They are not branches of other nerves, okay? But among humans, okay, they are still hypotheses, no? Even their functions, no? The terminal, they are saying that it is, I mean, for olfaction, for sexual arousal, and the like, no? Pero wala pa. They are only just hypothesis or educated guess, okay? Hence, we only have 12 cranial nerves, okay? So probably, in the near future, they might add this one, 13 and then 14. But strictly speaking, there is no consensus among neuroanatomists and neurologists to include cranial nerve number 13 and cranial nerve number 14, okay? So just always remember, no, the different functions of the different cranial nerves. Okay, so always remember the different functions. That's your assignment. It was already discussed during your neuroanatomy. Okay, so now, okay, we'll now go to the second question. Okay, how about palakwan, cerebellum? Okay, so again, for the cerebellum, so the cerebellum is actually divided into three lobes, right? So the anterior lobe, no, the posterior lobe, and your flocculonodular lobe. Okay? So you know that already. The anterior lobe is also known as your pallius cerebellum. The posterior lobe is your neocerebellum, and the flocculonodular lobe is your archicerebellum. Okay? And of course, the cerebellum do have specific functions. Okay, so we have your coordination, balance, and of course, tone and posture. Okay? Okay, we know that the coordination is actually the function of your neocerebellum. It's the newest function, no? The balance is the function of your archicerebellum, and the tone and posture is the function of your paliocerebellum. Okay? Just remember those things, no? And of course, the somatotopic organization, okay, or representation of the cerebellum. Cerebellum is again subdivided into two main areas, no? Your hemisphere and your vermis. Okay? So always remember that in the vermis, it's more on for your trunk, no? While in the hemispheric region, it's your upper limbs and lower limbs, okay? Such that if you have, for example, abnormality or dysmetria or ataxia in the upper or lower limb, it should be located primarily in the hemisphere. But if it is a truncal ataxia, it is in the vermian region, okay? Do you get that? And of course, you should know the different cerebellar signs, no? Dysmetria, finger to nose test, dysdiadochokinesia, kinesia, okay, or the pronation supination test, and of course tandem gait, no? For the lower extremities, of course, you have the knee to heel, or knee to shin to heel, no? Test, okay? So you should, and remember again that it is always ipsilateral to the lesion, okay? Do you have any questions regarding the localization of brainstem and then your cerebellum? Okay. Now again, always remember that not only the different cranial nerves are located in the brainstem, we have also others, no? So for example, your red nucleus, okay? So your red nucleus, always remember, are located in where? A, midbrain, B, pons, C, medulla. Okay, very good, Dennis, no? So it's in the midbrain. So always remember that any lesion above the midbrain or above the red nucleus will cause decorticate or decerebrate. Decorticate, okay? So any lesion above the red nucleus will cause decorticate, and then any lesion below the red nucleus will cause decerebrate posturing, okay? So if this is the red nucleus, no? And then another is, of course, your substantia nigra. Okay, substantia nigra is located where? Midbrain, pons, or medulla? Midbrain, pons, or medulla? Okay, located in the they are located in the midbrain, right? Okay, the substantia nigra will actually delineate the tegmentum and your basis, di ba? Now, the clinical implication is this substantia nigra produces dopamine that when depleted will actually lead to a disorder known as your Parkinson's disease. Okay? Okay, sige. So that is for the localization part. Okay? Now, we will now go to, is there a neurologic problem? Okay? So what I mean here is, when a patient will go to you, no, came in, secondary to a symptom, these are the different symptoms that immediately you will think that your lesion is in the posterior fossa level. Okay? So if you encounter these different symptoms, always remember to focus our attention that more likely you are dealing with a posterior fossa lesion. Okay? So number one, okay, you know this one na eh, the D's, different D's, right? Dizziness, diplopia, no? Dysphagia, dysarthria, okay, and deafness, okay? So these are actually the different symptoms that when, for example, this is the main complaint of your patient, more likely you are dealing with a posterior fossa lesion, okay? So number one is dizziness, okay? So I actually intentionally put some of my travel, no, to just tickle or stimulate your reward system. Okay, of course, the most rewarding part for us, no, doctors, is seeing our patients treated well, no, okay, or they are saying thank you to you because you are now okay, fine, no, okay. But of course, one also of the most satisfying or rewarding is you can actually travel around the world with for free, okay. How? Okay, so of course, number one, you should have a good research, no? Sometimes, different conventions will give you travel grants, no? Such that you can go in that convention for free, okay? So number two, if you will build a good practice, no? So probably your institution will actually send you to some conventions for continuing medical education, and they will pay all, no? So, and I believe it will all start in medical school. Okay? So, of course, reviewing, studying is not overnight. No? Building a good practice is not overnight. It will actually start here in medical school. No? So, always remember to, of course, study hard. No? Think of your parents, their sacrifices. No? So that in the future, you will not only treat patients, but you can actually bring them outside the country, of course, hopefully without this pandemic, no? Probably for free or very little expenses, no? Okay, so dizziness. So dizziness is defined as disorientation of oneself to the space or to the environment. Okay, so as if you are seeing the objects moving or yourself is moving. Okay, pero hindi naman. Okay, so you are only perceiving it or feel, there is only the feeling of it. No? Okay, so this was taken in Dubai. No? Okay, in Dubai. So I actually felt very dizzy during the trip, okay, using these cars, okay. But at the end of the day, it is actually fulfilling to see the beautiful sun and sand of Dubai, okay. So when a patient will go to UK due to dizziness, there are actually immediately you should think of these four types of dizziness. There are actually four types of dizziness. Okay, so number one is rotatory or the vertiginous, okay, or the peripheral dizziness, no? Number two is disequilibrium or the feeling of imbalance or the central type of dizziness. And number three is pre-syncope. Okay, when we see syncope, it is actually the actual loss of consciousness. So nahimatay siya, okay? Secondary to poor oxygenation to the brain. So when we see pre-syncope, there is a feeling of as if the patient will lose his consciousness, okay? So that is actually parang dizzy, okay, yung feeling niya. So that is pre-syncope. And more likely, this is secondary to decreased oxygenation, okay? Or some metabolic problem like hypoglycemia, gutom ka, no? You are hungry, you are hypoglycemic, no? So it can actually cause syncope or pre-syncopal attack, no? Others include hyponatremia, decreased sodium, no? It can actually cause a pre-syncopal attack, okay? And of course, number 4 is psychogenic, no? So psychogenic syncope is a diagnosis of exclusion. So meaning you should first rule out the different causes, these different causes of syncope, and then usually they are associated with panic attacks, no, depression, okay, or some hello, or some severe emotional attacks, okay? Can you hear me?
Yes po.
Okay, sige. So that is for your psychogenic and pre-syncope, okay? But more importantly, you should be able to differentiate peripheral from a central type of dizziness, okay? So how will you do that? Of course, the patient will go to you, came in due to dizziness, okay? And you should do your neurological examination, history, and the like, okay? So peripheral, and then central, okay? So when we say peripheral dizziness, these are secondary to lesion, okay, in the inner ear, okay? Particularly the semicircular canal, the utricle, and your saccule, okay? That is for your peripheral, okay? While for your central, these are actually lesions in the cranial nerves, okay? Your vestibulocochlear, your cranial nerve number 8, of course, cerebellum, cranial nerve number 8, of course, cerebellum, okay? And of course, your cerebellum. So, central yan, okay? So, dizziness. So, usually, for the peripheral, it's rotatory, okay? So, umiikot, no? Rotatory. But for central, it is non-rotatory, okay? So, usually, there is disequilibrium or imbalance, no? Ang sabi nila, para daw silang lasing, no? That is for central, parang lasing, yung feeling, no? That is for central, okay? Number 2 is the onset or duration. So usually, for the peripheral, it is less than 2 minutes. Very brief lang siya, no? Rotatory, and then after some time, it will disappear, okay? And then it will again reappear, okay? That's why it is called paroxysmal vertigo, because it's on and off, no? But for central, it's more than 2 minutes, okay? Usually days or weeks, no? That is for central, okay? Then you should also note for nystagmus. Nystagmus is the movement of the eye, okay? When you move your eye, there are actually involuntary movement of those or oscillation of the eye, okay? So for the peripheral, okay, so for the peripheral type of nystagmus, okay, usually they are mixed, okay? When we see mixed type of nystagmus, you can actually see horizontal nystagmus or vertical nystagmus. Okay, but for central, they are always pure. Okay, so exclusively, there should be only a peripheral horizontal nystagmus or a vertical nystagmus. Okay, and then of course, presence of tinnitus. Usually, it is present. Tinnitus is abnormal ringing in the ear. No? They are usually seen among peripheral vertigo, but they are not present in central type of dizziness. Okay? And of course, presence of cerebellar signs, no? Like your dysmetria. Of course, negative for peripheral, and then positive for central type of dizziness. Okay? So always remember that these are actually the different symptoms or signs that you should know in order for you to differentiate a peripheral from a central type of lesion. Now, why do we want to differentiate them? Of course, central is more life-threatening, no? It can actually cause death among patients. We have actually patients complaining of, I have a referral just now lang, no? The patient from mga Tarem actually, the patient is complaining of dizziness last night, no? Pero ngayon, GCS6 na. Okay, so probably they treated the patient as vertigo in their town, okay, but the patient was already transferred here. because of course of deterioration of sensorium. So more likely, you are entertaining a central type of dizziness there, no? And if you are entertaining a central type of dizziness, of course, it is an emergency. Because remember that the ARAS, as well as the cardiorespiratory center, are located in the posterior fossa, that when they are compressed or damaged, it can actually cause death or coma to the patient. Okay? Do you get that? Okay, so when a patient will go to you complaining of dizziness, always remember, is this a peripheral type of dizziness or is this a central type of dizziness? Okay? And then for the treatment, of course, you will learn that in your pharma and in your neuro too. Okay? Do you have any questions regarding the peripheral and central type of dizziness? Okay, that is for dizziness, no? Number 2 is diplopia. Okay, so as you can see here, you are not having diplopia. Diplopia meaning doubling of vision. Okay, this was taken in Kuala Lumpur. No, this trip is very memorable to me because this is my first time to go abroad because of a research study. No, I actually presented a research in Kuala Lumpur. Okay, so probably you can start your research now, no? So when we say diplopia, there is actually a doubling of vision secondary to impairment, of course, of the different muscles, extraocular muscles, okay? So let me give you again the different functions of your muscle, okay? So for example, this is your eyes again, no? I know you all know this. Okay, so we have here the lateral movement or your abduction, okay, or your lateral movement going here. And then here is your adduction. So here is your nose, no? Nasal area. So your adduction, no? And of course, superiorly. So abduction, what muscle? Your lateral rectus, okay? And then your adduction, adduction is medial rectus. Okay. And then looking up, or yeah, looking up here, it is actually, there are actually two here, no? Two muscles. Your superior rectus, and then your inferior oblique. Okay, inferior oblique muscle, no? And then looking down, there are also two muscles here, your inferior rectus and then your superior oblique. So as you can see, it's the opposite, no? If they are oblique muscles, okay, the one that will cause downward gaze is your superior oblique, not your inferior oblique. Okay, so another, of course, when we see superior rectus, it will cause outward or in extorsion. Okay, extorsion. Here, it is also extorsion, okay, or outward. While for oblique muscle, they will cause intorsion, okay, or inward. Intorsion, okay? So always remember the different functions of your different muscles, okay? And of course, you know the different cranial nerves. So as a rule, all extraocular muscles is innervated by your cranial nerve number 3, except your lateral rectus and your superior oblique. Okay? Because your lateral rectus is innervated by the abducens nerve. That's why it will cause abduction. And the superior oblique is innervated by your trochlear nerve. Okay? So always remember that. But the medial rectus, superior rectus, inferior rectus, and your inferior oblique will be innervated by your cranial nerve number 3. So any weakness or paralysis of the different muscles will actually cause diplopia or doubling of vision. Okay? Do you get that? So that is for diplopia, no? And then dysarthria. So this was taken in Pisa, no, in Italy. So as you can see, the Pisa is deviated, no? It's like the tongue. It's deviated to the left. Okay, so when we see dysarthria, okay, so slurring of speech, there are actually 3 cranial nerves that are involved, okay, or more likely involved, okay. So they can be independently involved or a combination of them, okay. So what are these muscle? So everybody can kindly say me, 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 me. Me, 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 me. Okay, when you say me, 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 you are actually moving your orbicularis oris, right? And orbicularis oris is innervated by your cranial nerve number 7, okay? Facial of expression, okay? Me, 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 okay? Everybody say ka, 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 okay? Ka, 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 okay? Ka, 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 ka. Your pharyngeal, as you can see, no, the movement is inside the pharyngeal area. Okay, so it is the different pharyngeal muscles, primarily innervated by your cranial nerve number 9 and 10, and last, la 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 la. Okay, so when we say la 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 la, as you can see, your tongue is moving, no? So it's your cranial nerve number 12. Okay, so these are actually quick test in order for you to know where is the lesion. So for example, the patient will go to you, came in due to dysarthria, okay, and then there is inability to say ka 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 ka. So more likely there is cranial nerve number 9 and 10, okay, and in neurological examination, you also noted uvula is deviated to the right or left, okay, or la 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 la, tongue, no? And then on neurological examination, you noted that the tongue is deviated also, okay? So those are actually quick tests that you can actually do in order for you to differentiate where is the, or localize more likely where is the lesion, okay? Do you get that? Okay, so just like this, no? Tongue is deviated to the right, okay? So always remember it is ipsilateral to the lesion. Okay. So during your last examination, probably you were confused, no? Regarding a peripheral facial palsy and a central facial palsy. When we see central facial palsy, it is a supratentorial lesion. Okay? When we say peripheral facial palsy, infratentorial. So how will you differentiate, no? So as you can see here, the facial area can be divided into an upper part and the lower part, okay? If both the upper part and the lower part is affected, it is a peripheral facial palsy, and it is more likely an infratentorial, no? Prototype example here is your Bell's palsy, okay? Bell's palsy is an isolated cranial nerve number 7 palsy, okay? While when we say central facial palsy, there is preservation, no, of the forehead. The upper part of the face is preserved, while the lower part is paralyzed. Okay? So more likely, you have a central facial palsy or lesion inside the brain. Okay? So do you still remember the homunculus? So if, for example, this is the brain, no? So this anterior part, more on the leg yan. Okay, legs. And then here is your arms. And then here is your face, facial region. So more likely, if you have a central facial palsy, you have actually a lesion here in the facial portion, okay, or representation, okay? And of course, as I have said, tongue, pharyngeal, deviated to the left. When, okay, so when there is a deviation to the left, when there is a deviation to the left, where do you think is the lesion? Right or left? Deviation to the left. Where do you think is the lesion? Right or left? Right. Okay, so always remember that, right. But when we are talking about the tongue, it is pointing out to the lesion. Okay? So always remember that. Okay, dysphagia. So dysphagia, difficulty swallowing or inability to swallow. Okay, so this was taken in Tuscany, no, in Italy. So as you can see, dito daw yung best ice cream in the world, no? Pero mas masarap pa yung ice cream natin actually, no? So when we see dysphagia, when a patient will go to you, no, complaining of dysphagia, the first thing that you should note is this secondary to the patient cannot swallow, secondary to an obstruction in the esophagus or in the stomach, or there is a lesion in the nerves or in the brain, okay, such that the patient cannot swallow. How will you do that, no? So let the patient drink 3 ounces of water. Okay, this is actually the 3 ounce test. When the patient can swallow the water with difficulty, okay, so the patient, so 3 ounce test, so 3 ounce test, if the patient can swallow it with difficulty, okay, meaning there, you will know terminal cough. So iinom siya, the patient will drink and then uubuhin siya. Okay, more likely you are dealing with a central dysphagia. Okay, meaning you might have a cranial nerve number 9 or a cranial nerve number 10 problem. Okay, but if the patient can tolerate, okay, easy ang water but difficult ang solid, okay, difficulty in swallowing solid, more likely there is an obstruction, okay, in the esophageal area. Okay, so that is how you will actually differentiate them. Okay, that is very important because sometimes, for example, we have again a patient, no, complaining of dysphagia. So the patient underwent several procedures such as barium swallow, chest CT scan, abdominal ultrasound, and etc. etc. It's all negative. Okay, only to find out that there is a uvula deviated to the right, no? So kaya pala hindi makalunok kasi ang problem is in the nerve. Okay? So do you get my point? So it's very time consuming and then financially draining to the patient if you will not do the correct approach. Okay? Okay, so another is deafness, okay, or hearing loss. Okay, so this was taken in Paris. Okay, so yan, makakonect lang, may earphone. Okay, so hearing loss. I hope tumatawa kayo sa joke ko. So deafness. So deafness, of course, hearing loss, no? So hearing loss can actually be divided into 2, no? We have the conductive hearing loss and sensory neural hearing loss. Okay, when we say conductive hearing loss, okay, so these are actually secondary to, of course, lesion of your external ear or your middle ear, okay? But for sensory, secondary to cochlear problem up to the brainstem up to the central, okay? Primary auditory cortex in the temporal region, okay? So how will you do that? Of course, by doing this test. Weber's test, okay, this one, and Renee's test. Okay, so this is your assignment. Ha? Okay, so usually, Weber's test is more on where it will lateralize. Okay, while Renee's test, what is greater? Air conduction or your bone conduction. Okay, so yon, you can actually differentiate a conductive from a neural hearing problem based on Weber's and Renee's test. Okay? Okay. So that is for your deafness. Okay. Now, we will now go to the third question. Do you have any questions? So if, for example, a patient will go to you secondary to those different Ds, always remember that we are dealing with a posterior fossa lesion. Okay. Now, we'll now go to the what is the nature of the lesion. We have again here our mnemonics. No? Do you still remember our mnemonics? V is for hello?
Vascular.
Okay, good. Vascular, and then? infectious, toxic, autoimmune, metabolic, no? Inflammatory or idiopathic or iatrogenic, neoplastic, congenital, and degenerative. Okay. Based on the history of the patient, usually vascular is sudden, right? And then infectious, of course, presence of fever. Toxic, of course, presence of a toxic metabolite or toxic substances. Autoimmune, presence of an autoimmune problem. Metabolic, presence of a metabolic problem such as, of course, hyponatremia and all. Iatrogenic, doctor-induced. Neoplastic. So usually neoplastic is, in contrast to vascular which is sudden, neoplastic is usually progressive, right? And chronic. Progressive, chronic, and then gradual. Okay? For congenital, okay, present at birth. And then degenerative are also progressive. Okay? But usually, it will take longer years, no? Than that of the neoplastic. Okay? So now, when, for example, you already did your neurological examination and then what is the nature of the lesion, I will tell you the most common differential diagnosis, no? The most common differential diagnosis in if we are talking about the vascular, inflammatory, and all. Okay? Now, so for your assignment, I know you all know this, okay? So your vascular lesion, so the different vascular symptoms, Benedict's, Digerin, Weber's, and then Wallenberg, okay? So always remember these different syndromes. Okay, that is for your vascular, again, sudden, okay? Okay, by the way, from now on, okay, I only learned this when I was already reviewing the board examination. It would be very easy for you to remember things if you will tabulate them, okay? So we'll do it now, okay? So it's like this. So tabulate. So of course, here is the disease, and then followed by the epidemiology or the prevalence, and then followed by the symptoms or the clinical manifestation, okay, and then pathology, okay, the cause, okay, and then the diagnostics, okay, right ha, magsulat kayo dyan, then therapeutics, and then of course the prognosis, okay. So all disease entity, no, you should have a book or you should have a file na of this one, okay, so that when you will encounter them again and then you have new ideas regarding that illness, you can just put it there, okay? But more so, ito yung 6, okay, most commonly asked questions, no, during board examination. So you should know them by heart. You must know them, okay? So again, vascular lesion. For epidemiology, of course, more on elderly patients, no? More than 60 years old, okay? Symptoms, sudden onset, okay? It will be dependent on what part of the brain is affected, right? Okay? For pathology, most common risk factor include age, hypertension, diabetes mellitus, dyslipidemia, or high cholesterol, and of course, atrial fibrillation, irregular heart rate and rhythm, okay? Diagnostic, of course, it will be dependent. If we are talking about infarct, MRI or CT scan? Kapag infarct, MRI, okay? Kapag bleed, of course, CT scan, okay? So always remember that. Therapeutics, of course, it will be dependent. If it's bleed, you control the BP, okay? If it's infarct, you can give antiplatelet or anticoagulant, okay? Prognosis, depende, of course, no? On how severe the stroke is. Okay, so that is for your vascular, okay? Number 2 is infectious. Letter I, infectious. The most common here is cerebralitis. Of course, cerebralitis is inflammation of the cerebellum, okay? So, cerebralitis is also known as your acute ataxia among childhood, okay? So, cerebralitis, acute ataxia, okay, among childhood, no? So more commonly, they are seen among children, no? For the symptoms, okay, usually, of course, positive for fever yan. Okay? And then they will have ataxia. Okay? Both limb and gait ataxia. So the whole of the cerebellum is affected, the vermian as well as the hemispheric region are affected. Okay? For the pathology, the most common virus is your varicella zoster virus, and then Epstein-Barr virus, your kissing disease, the mycoplasma, okay, and your cytomegaloviruses. Okay, so these are the different microorganisms implicated in patients with cerebralitis. Diagnostics, of course, the gold standard is CSF analysis. Okay, you'll do lumbar puncture and then do CSF analysis. Treatment, antiviral medications. Okay, usually for the prognosis, slow recovery, no? Very slow recovery, okay? And sometimes very high mortality, okay? So that is for cerebralitis. Okay? And then toxic. So for the toxic, siguro most of you, meron na nito, alcoholic cerebellar degeneration, okay? So always remember that ethanol, okay, alcohol, do have predilection to the cerebellum, okay? So for the alcoholic cerebellar degeneration, more commonly for the epidemiology, of course, male, okay? And then usually it will affect the vermian region, okay? That's why it will cause truncal ataxia, okay? Not limb ataxia, okay? So if you are a nurse, no, sometimes they are actually doing alcohol test among bystanders, ganon. So what you are doing is the tandem gait, no? So usually talagang meron silang truncal ataxia, okay? And then for the pathology, of course, chronic alcoholism, okay? It can actually cause loss for the pathology. This alcohol can actually cause loss of Purkinje cells. Okay? So remember the different Purkinje cells in the cerebellum. Okay? And then, for the diagnostics, MRI. Okay? You can actually see atrophy of the vermian region. Okay? Therapeutic, you can detoxify them using vitamin B complex, no? Or you can probably rehabilitate them, no? So that is for the therapeutics. Okay, that is for alcohol. Autoimmune, okay? So, prototype example of an autoimmune posterior fossa level lesion is your Bickerstaff brainstem encephalitis, okay? So, Bickerstaff brainstem encephalitis. So, usually, actually, it's rare eh. So, Bickerstaff, it is actually rare, no? They cannot say if it's more common among children, male, female, etc., no? But the most common manifestation, since it affects the brainstem, it can cause ophthalmoplegia, no? Or diplopia, okay? Ophthalmoplegia or diplopia, and then, of course, ataxia, okay? And then for the pathology, presence of anti-ganglioside antibody, okay? Since it is an autoimmune, ganglioside antibody. Okay, and then for the diagnostics, you can actually test for the antibody itself, no? And then for the treatment, since it's an autoimmune, you can actually give steroids, okay, or IVIG, intravenous immunoglobulin, or plasmapheresis, no? When you see plasmapheresis, you will actually, para siyang dialysis, no? You will remove the plasma and then, because remember that the antibody is actually found in the plasma of the person, no? So we'll remove that. Kagaya ng mga COVID ngayon, di ba? They will actually remove the plasma, then doon yung antibody, and then they will give it to another person, okay? So just removing that of the plasma, okay? And then prognosis, it's very poor, no? The prognosis of Bickerstaff is very poor. Sinusulat nyo ba? Sinusulat nyo ba? Hello?
Yes po.
Okay. And then another is, for the metabolic, letter M, It's your central puntine myelinolysis. Okay, so there is myelinolysis in the puntine region. Okay, so the usual history of this is a patient came in due to LBM, no? And then you have or you requested for electrolytes, and then the sodium is very low. And then you are actually very eager to correct the sodium. Okay? And then after which, after 3 days, the patient, wala na yung LBM niya, but the patient is actually experiencing quadriparesis, ophthalmoplegia, okay? Because rapid correction of sodium can actually cause myelin destruction, okay? And it, of course, it will cause several manifestations, no? So central puntine myelinolysis, they are seen more commonly among male, okay? Ito din, I don't know if you encountered that, no? A patient daw, uminom siya ng energy drink after exercising ata, and then nakomatose siya after 1 day, no? So usually, that is rapid correction of sodium, okay? And it will actually cause osmotic demyelination, and it can cause comatose, no? And probably death among patient, no? For clinical manifestation, yun lang yung kanila, hypothesis nila. So more likely, ganun siguro yung nangyari. So, rapid or osmotic demyelination. So, quadriparesis, of course, it will affect the end of ophthalmoplegia. Okay? And then for the pathology, of course, rapid correction of sodium. Okay? You should only correct sodium about 10 mEq per day lang. Okay? 10 mEq per day. Huwag kang very eager na pauwiin yung pasyente mo, no? Kasi usually ganun, if you are a resident, you want to dispose your patient early and then you do rapid correction, it might actually cause harm to your patient, no? So for that diagnostics, MRI also, you can actually see the demyelination in MRI. And of course, for the treatment, physical therapy, okay? You can, and the prognosis is actually very poor, no? Okay, that is for your metabolic. Neoplastic, okay? So there are actually 2 here. Your vestibular schwannoma. Okay, so the schwannoma is actually located here. This is your schwannoma. As you can see, they are located in the cerebello-puntine angle. Okay? So always remember that in this area, so if for example, this is your midbrain, pons, and then medulla, okay? The cerebellum is actually here, no? The cerebellopontine area is here, no? It is actually where cranial nerve number 7 and cranial nerve number 8 exit. Okay, so if you have, for example, a lesion here in this region, it will actually compress cranial nerve number 7, causing hearing loss, and cranial nerve number 8 causing hearing loss, and then cranial nerve number 7 that will cause a facial palsy. And of course, the patient will also have cerebellar sign, okay? That is for your vestibular schwannoma, okay? So vestibular schwannoma, okay, usually, the peak incidence is 30 years old, no? They are seen among 30 years old. For the clinical manifestation, as we have said, hearing loss, facial palsy, no? And of course, disequilibrium. Okay, so those are the different clinical manifestation. As you can see, di ba kanina, no, dun sa picture, no? And then for the pathology, loss of tumor suppressor gene in chromosome number 22. Okay? And then of course, for the diagnostic, when we see neoplastic, you should always do MRI with contrast. For the treatment, surgical, okay? You should remove the tumor. Actually, the prognosis is good, okay? Kapag early stage pa lang. Pero kapag it will already compress the cerebellum causing hydrocephalus, definitely it's poor, okay? Another neoplastic tumor, so ito yon. So as you can see, they are located in the cerebellopontine angle. Okay? It's a schwannoma, no? Vestibular schwannoma. Schwann cells. Okay? So, nagiging tumor siya. Another is this one, medulloblastoma. Okay? Its most common origin or location is your vermis. So, as you can see, if it's vermis, the manifestation is, of course, what type of ataxia? It's, again, truncal ataxia. Okay? So, it's, again, truncal ataxia. So, medulloblastoma. Okay, more commonly, they are seen among children, 9 years old and below. Okay? Always remember that this is actually the most common solid malignant tumor among children. Okay? So, medulloblastoma is the most common solid malignant tumor among children. Okay? So, since it affects the vermis, it will cause truncal ataxia. Okay? And then, for the pathology, it is actually sporadic, no? Okay, and then diagnostics, MRI again, and then treatment is surgery, okay? So usually for the prognosis, it's poor prognosis if the patient is 3 years old and below. So kapag 3 years old and below yung patient, hindi siya maganda, okay? That is for your neoplastic. Okay? We'll now go to the congenital or hereditary. Okay? There are actually two here. This one, Dundee-Walker syndrome. Okay? Or your Dundee-Walker anomaly. Okay? So since, of course, for the epidemiology among children, as you can see here, there is an absent of your vermis. Okay? So, agenesis of the vermis. And then, here is your fourth ventricle. There is a cystic dilatation of the ventricle. That's why it called cyst, no? Cystic dilatation of the fourth ventricle. And then there is an enlarged posterior fossa, okay? So yun yung triad ng Dundee-Walker, okay? So absent vermis. And then we have the fourth ventricle dilatation, okay? And then cystic cystic dilatation or enlarged, no? Yung kanilang posterior fossa. Okay? Usually, they are associated also with hydrocephalus. Okay? So for the diagnostic, of course, MRI. And then for treatment, you can do VP shunting if positive for hydrocephalus. Pero usually, andyan na yan eh. No? Lifetime na for the prognosis. No? Sometimes, it's very mild. No? Incidental finding lang sila. Another is this one, Chiari malformation. Okay? Sinong Ilocano dito? Meron ba? Okay, so in Chiari malformation, of course, they are seen among children again for the epidemiology. Okay? And then, the pathology here is this one. There is actually protrusion. Protrusion of your cerebellum here in the foramen magnum, okay? So kaya ko tinanong kung merong Ilocano dito kasi ang code ko is Ki, di ba? Chiari, tumaktak ki. Merong protrusion doon, okay? So if there is a protrusion of cerebellar tissue, okay, that's called Chiari malformation. Usually they are also associated with hydrocephalus, okay? And then for the diagnostics, MRI, treatment, of course, VP shunting lang if you have hydrocephalus. And then prognosis, lifetime. Okay? Now, for the degenerative, okay, so the prototype example here is your Holmes cerebellar degeneration. For the epidemiology, they are usually seen among 30 years old and above. Okay? Of course, the whole of the cerebellum is affected. So it will cause limb ataxia, and truncal ataxia. Okay? MRI is the diagnostic of choice. For the pathology, it is also sporadic. You can actually see symmetric atrophy of the cerebellar hemisphere and the vermis area. Okay? So, atrophy, no? Symmetric. For the treatment, actually, wala. Degenerative kasi siya. And then, for the prognosis, it is also poor prognosis. I mean, it's not if it is very mild, it would be good prognosis, no? Pero kapag severe, of course, it will cause disequilibrium to your patient. The patient cannot walk, no? And then the patient cannot work, okay? So those are, of course, the different nature of the lesions. The last question is, what can we do to that lesion? Of course, you already discussed that, the diagnostic and then the therapeutic side. And we will, during your second year, this will be discussed further on, okay? So in summary, so always remember that if you have your 4Ds, probably that is a posterior fossa lesion, no? So always infratentorial, always ipsilateral to the lesion, and then it will be dependent on your localization, what are the cranial nerves affected, okay? And then, of course, the different prototype example or most common example on the nature of the illness, okay? So do you have any questions? Do you have any questions? Okay, so if none, may questions ba kayo? Wala. So if none, thank you very much, and you will have your exam on Thursday, right? 1 to 3 p.m., tama ba? Or 3 to 5? 1 to 3. Okay, 1 to 3 p.m. Then after your exam, you will have your lecture with Dr. Tulagan, I think.
Doc, na-move na po.
Na-move na. Ano na tayo? 1 to 3 or 3 to 5?
Yung ano po, Doc, yung exam po, 1 to 3 pa rin po. Pero na-move
Okay.
po
Yung
na
kay Dr. Tulagan, minove nyo na. Okay. So your exam is 1 to 3 p.m., 25 points each topic. Okay? So MCQ again. So always remember to submit your work before the due time. Okay? In order for you not to get zero. No? Okay? So thank you very much and God bless.
Thank you, Doc.
Thank you, Doc.